Watch and wait really means just that. Instead of initiating some treatment with the goal of raising the platelet count, that might cause some side effects. In some instances, it's actually more appropriate to monitor the child. It can seem like that we're doing nothing, but the value of the ongoing observation and review of the symptoms is what really is important.
Welcome to our special ITP in Kids series, part of the Beyond the Count podcast. This series is dedicated to children living with immune thrombocytopenia and the families who support them. We'll be exploring everything from diagnosis and treatment to school, sports and emotional well-being. We'll speak with leading ITP clinicians, hear from parents who've walked this path, and even chat with kids themselves, giving you a full 360-degree view of what life with ITP really looks like. Whether your child has just been diagnosed with ITP or you've been managing ITP for a while. This series is here to support you, inform you, and empower you every single step of the way. In today's episode, we're talking about something that can feel really counterintuitive when your child has just been diagnosed with ITP, being told to do nothing. Or at least that's how it can feel. Because as a parent, your instinct is to act, to fix it, to do something that makes it all better. But in paediatric ITP, one of the most common and recommended approaches is what we call watch and wait. In this conversation, Dr Melanie Jackson helps us understand what that actually means in real life. We talk about why many children recover without treatment, how doctors assess bleeding risk rather than just looking at a platelet count, and what parents can do safely to support their child during this phase. We also step through the moments where treatment does become necessary and what this might actually look like. This episode is all about helping you shift from fear to understanding so you can feel more confident in what can otherwise feel like a really uncertain time. Let's get into it. A huge welcome back to Melanie for the ITP in Kids series. Thanks so much for joining us again.
Thanks, Danny. It's great to be here. I love having these chats with you.
Oh, it's so much fun. It's absolutely so much fun. And congratulations on the first episode. It is absolutely doing gangbusters. Now, today we're actually going to be talking about the watch and wait method when it comes to paediatric ITP. What does watch and wait actually mean in ITP care from a kid's perspective?
Yeah, so when a child's first diagnosed with ITP, there might be some bruising or some petechiae, a nosebleed, something like that that might prompt them to get a blood test, and we'll find that their platelet count is very low. All other things are assessed and ultimately a diagnosis of ITP is come to. Watch and wait really means just that. Instead of initiating some treatment with the goal of raising the platelet count, in some instances it's actually more appropriate to sit tight, to monitor the child, to continue to reassess the child, and to wait to see what the trend in the platelet count is before initiating a treatment that might cause some side effects and that won't necessarily cause a long-lasting response in the platelet count on its own.
Wow. And so this is really, it's very different to the way that I suppose adults are treated, because generally it's straight onto treatment, let's try and sort of kick this into gear. And it's a really beautiful approach. I have to say, I'm quite envious that there is this opportunity to sit back and actually, watch the individual, watch the child to see, what's happening. Why is this approach often used in toddlers and young kids as opposed to adults?
Yeah, so this often is a way that we manage ITP because it acknowledges that really two aspects of ITP in paediatrics. Firstly, many will get better on their own, with many patients returning to normal within 3 to 6 months without any treatment, many actually even much sooner than that. And also that we know the risk of severe bleeding in paediatric ITP is very low. Often this is, in terms of severe life-threatening bleeding, this is less than 1% of patients, or less than 3% having some sort of significant bleeding event. Now, of course, this is not 0%, and nobody wants their child to be in that small number of patients that have serious bleeding. However, part of the watch and wait approach is assessing the child and determining by how they are presenting what their phenotype or symptoms are to prognosticate what the risk is of their bleeding. So we review children and we look at their bleeding symptoms. Many of them are having petechiae or bruising, but those things don't necessarily mean that they fall into the high-risk category. Bleeding symptoms that make us more worried and make us feel that the watch and wait approach is perhaps not appropriate includes a lot of blood blisters in their mouth called wet purpura, prolonged nosebleeds that are not settling down, and this is both anterior nosebleeds or nosebleeds that are going the posterior part of their nose, blood in the nappy or blood in their urine or poops, heavy menstrual bleeding for our teenage patients. These are the things that we worry more about. And if patients are having these things, then we often abort the watch and wait approach. But if patients are not having these symptoms, we feel that their chance of a severe bleed is actually quite low, and risks of initiating a treatment might actually outweigh any benefit, especially since they may fall into that category that recovers very quickly, as more than 50% of patients will do.
Yeah, and that's really important as well. Actually, identifying what's actually happening in the individual and in the child, and I think it's a really good process to see all of these factors before making any serious decisions. So, what can I suppose parents or the primary carers of these children do during this particular phase of ITP for their child?
So I suppose that's multifactorial. So there's a few things the parents can do. So firstly, they can be part of the watch and wait process. So we're relying on them to monitor their bleeding symptoms. For children that will happily open their mouth, having a look in the mouth, looking for those blood blisters can be very helpful for us we might only see them from time to time. In many cases, when they're far away, we might be relying on telehealth appointments. So it's really helpful if parents can be looking in their mouth, looking for bleeding. Monitoring nosebleeds. If patients are having nosebleeds, initiating first aid, so pinching that area below the nose, leaning forward, holding it for a good 5 minutes before assessing to see if that nosebleed is still flowing, and also keeping time of how long the nosebleeds are lasting. If they are more than, say, about 15 minutes, we do often recommend coming in. Having a look at the child's toileting habit, depending on their age appropriateness. So looking at the urine and looking at the stool to see if there's any blood mixed in with those things. If you've got a teenage female patient, asking about their periods, how long their periods are lasting, how many times a day they're needing to change. Are they needing to change sheets overnight, which might be one of the more apparent things. I often see teenage patients who are not having those discussions with their parents, and that can be very important to sort of assess just how bad the bleeding is. Teenagers will often say that, things are fine, my periods aren't heavy, but they don't often know what normal is, because this is only new to them, especially if they have a diagnosis of ITP. And then I suppose in terms of other things that parents can do is support them into making, whether they be toddlers or teenagers, obviously different activities that the kids are looking to do. So to support them to still be able to live an active life, to still be able to do activities that bring them joy. But there are some limitations on if we've got a very low platelet count and we are just watching and waiting, on what activities we might accept as safe. Ultimately, it is the family and the parent together's decision. We can make recommendations on what is safe, but things that I often recommend if they're a toddler of daycare type age, preschool age, then making sure they've always got adequate supervision, making sure that they're not climbing distances above sort of their head height where they could fall, particularly not without helmets, riding bikes or any of those types of equipment, scooters, wearing a helmet, not necessarily not doing the activity at all, but taking the right safety precautions. And then in those teenage patients, that might be modifying their activity. So things like martial arts with high risk of head strike or rugby, they're the sports that we're a little bit more worried about if they're playing with a very low count. However, in saying that, if patients are into these thoughts and this is part of their normal quality of life and their normal daily living, then that's also can be an indication that the wait and watch approach might not be appropriate for them. Because part of the whole point in managing paediatric ITP is we want them to be able to live an active lifestyle within some limitations and to be able to participate in their activities. And if they're a high-level baseball player or a high-level judo player, then maybe that means that the wait and watch approach is not suitable for them. Even if their bleeding phenotype, their bleeding symptoms are quite low.
And how do you, I suppose, juggle, those conversations with, the parents and the child at I suppose, especially a little bit older children, being able to be part of those conversations?
Yeah, so I suppose it's about getting to know your patient in those first few appointments and having adequate time, not just asking about symptoms, but also asking about what their normal activities are and what it is that they enjoy. You can have two patients with the same bleeding symptoms, the same platelet number, same age and weight, but one of them might like to play a lot of video games and one of them might like to be an active rugby player. And we manage those patients in somewhat different ways because their risk is different of bleeding. So firstly, if they're toddler age, getting to know the family, what their usual routine is that patient going to daycare? Is there sort of concerns about what the risk is when the child is outside of the parent's care? What their normal activities are? Do they do gym? Things like that, and having conversations with the parents and getting a feel for how the parents have responded to the child's ITP, because some families will look at the less than 1 or less than 3% risk of severe bleeding in a very different way to other families, and some families will put different safety measures in place, and neither is wrong or right. It's just it's about treating the whole family unit and understanding what sort of is bringing them concern. With teenagers, sometimes that does involve, and we do this in a lot of our medical conditions or when we're just seeing a patient, sometimes it does involve having a conversation with the teenager alone as well so that we can get a little bit more information. Often, many of our patients, teenage girls might not want to be having those conversations about monthly times in front of their dads, and in many cases that's culturally appropriate to have those conversations away from outside of other family members. So it's about sort of assessing the culture, assessing what's important for each and every child and making sure that we're asking those questions.
Yeah. The other thing to remember as well is that we have a resource specifically for daycare, school, etc. that, as family members, you can actually put a photo of your child so the daycare staff, that the school staff know physically who this child is, and these are some of the elements with their ITP. And if something was to happen, this is what you need to do. Now you calling GP or the parents or an ambulance straight away, depending on the phenotype and their ITP specifically as well. So there is definitely that resource, and it's free to download off our website as well. And we strongly recommend downloading that and updating that every year, because as children they change so quickly, and not just from an ITP perspective, the physicality changes quite a lot as well. So what little Jimmy looked like when he was 3 compared to when he's 6 is probably a little bit different.
For sure.
So making sure that you update those sorts of things.
Yeah,
as well.
And we definitely within our service use those documents and find that they're quite helpful. We have had some daycares that might have some ambivalence, but then when we talk to them, when we give them that resource, when we fill out those documents, they feel much better, and the families feel much better as well. And we have a lot of the haematology units around the country would have nurses associated with them, but we can always talk to the units as well, supporting of those documents and explaining the situation. And some families, many families are comfortable going to daycare. Some don't feel comfortable, and we can help them sort of feel more comfortable, but ultimately it is their decision and what works with their life and their lifestyle.
Yeah.
Thanks to our sponsor Sobi for their ongoing support of ITP Australia and New Zealand and our podcast Beyond the Count.
So you touched on it earlier. So what if you're in that watch and wait sort of phase and treatment has now become necessary? What are the usual first steps, and what do you look for?
Yeah. So, I mean, there can be a number of reasons, as we've alluded to, as to why treatment might be indicated. It might be a change in the symptoms. The child might get a very heavy nosebleed, a very heavy period. We might get another virus that changes the phenotype. Often we do find when a child is sick, their bleeding symptoms might get worse. They might get a lot of oral bleeding. Or it might be because of an activity that's coming up. It might be because of a surgery, appendicitis, tonsillectomy. Or again, because of activities and the interference with the ITP on the normal lifestyle. In those instances, we'd be talking about treatments. And of course, if there's serious bleeding or a head injury, then we definitely need to initiate treatment. The treatments really depend on how urgently we want to get the platelet count up. So we know we have our first line treatments in ITP, and they're what we call rescue treatments or temporizing treatments. So we talk about steroids, which can be oral or IV, usually oral in the first instance, which we try and do a short, sudden burst of steroids to sort of block the immune system a little bit and to allow the platelet count to come up. But we call this a temporizing or a rescue treatment because we know that this is a temporary fix. It will temporarily bring the platelet count up. But it will, as those steroids wean off, go back down. Some go back down very quickly. Some might take 4 to 6 weeks after that steroid burst. Now, ongoing steroids for children, whilst they're growing, whilst their brain is developing, and at the doses we need for ITP is not something that we usually initiate because it can be detrimental to other aspects of their life, particularly with the side effects. And we can have conversations with the families about that. The other thing to note is steroids, the response rate is about 75 to 80% of patients. So unfortunately, not all patients respond. And that's very similar to the other option, which is IVIG. So this is a donated blood product of other people's immune cells that's been processed by lifeblood or the blood bank. And giving an infusion of this, which takes a number of hours, in the order of 6 to 8 hours, can we don't exactly understand how it works, but we know it can overwhelm the patient's immune system and dull down that response that's happening with the ITP of the patient's own antibodies consuming the platelets. And again, in a temporizing fashion, the platelet count can temporarily go up. And in some instances, if we've got severe bleeding or sudden surgery that's needed or a bad head injury, we might actually give both of those things. And in the occasion, platelet transfusion as well. But as we all know, a platelet transfusion on its own or even in addition to these treatments is treated by the body just like the body's own natural platelets and that is consumed very rapidly. So that's why we're not giving platelet transfusions to these people. Usually we try some of these first-line therapies at least once before we potentially go on to what we call second-line therapies, such as the TPO receptor agonists, which are medicines which work on the blood factory or the bone marrow to increase the platelet count and potentially provide a longer-term solution for the ITP. And then we've got a handful of other immunosuppressive therapies as well that we can try for patients that don't respond to these therapies.
Yeah, and it's good to know that there is, I suppose, a bag of tricks sort of sitting there waiting just in case, some of these children do need treatment, but having that watch and wait period from a lack of toxicity perspective and just being able to manage and see what's actually happening is a really good thing. How do you explain, I suppose, the watch and wait process or approach to, parents and caregivers and family members?
Yeah, so how I sort of explain it is that it's not that it can seem like that we're doing nothing, but the value of the ongoing observation and review of the symptoms is what really is important in the watch and wait approach. So I explain that at the moment their child's bleeding symptoms is very reassuring that they're mild and not warranting treatment. It is quite likely, but we can never presume who will get better quickly and who will not. But the odds are that this will get better in weeks to months. And what we want to do is we want to continually reassess their symptoms and decide if they need any of these temporising treatments, and hopefully wait for their platelet count to slowly come up on its own. If it doesn't come up on its own, or if the symptoms or signs on examination change, then we want to start treatment sooner. And I do explain that, unfortunately, one of the frustrating parts of ITP, as we all know, we can never guess who's going to respond to which treatment. There's nothing that will tell us who will respond to steroids or who will respond to IVIG. And unfortunately, these things do have medications as well. So I only want to start them when I know the child really does need them.
And that's reassuring. So how do you, I suppose, walk parents through the watch and wait and, help to alleviate some of that anxiety? Their child is, just been diagnosed with ITP. They may have these particular bleeding symptoms. How do you help alleviate that?
So I suppose one of the most important things is to make sure that they know how to contact us if they have questions or if they have concerns or if their child's symptoms change. So I make sure that once they're integrated into our service that we have a contact card, and we make sure that they know how to contact us at any time of day and gear them with the information of what to look out for in terms of concerning symptoms. So really active bleeding, active nose bleeding that's not stopping despite those first aid measures, oral bleeding that's not stopping, sometimes oral bleeding associated to teeth falling out, trauma, new blood in the nappy or stool. I make sure that they're aware of the symptoms to look out for and how to contact us, or if they don't have a 24-hour contact pathway as our centre does, then what to do if they get those symptoms, so where to present. I make sure that they understand what's going on, that this is not leukemia. A lot of the GPs who don't see ITP so much might sort of see a platelet count of 2 and be quite alarmed that there's some sort of haematological malignancy going on. So reassure them that this is not something that's going to change to a malignant process and the normal natural history of how it might get better, but also reassure them that if it's not getting better, we have lots of treatment options out there to help. We just don't want to start them too soon if they're a particularly mild patient, because it might cause more harm than benefit.
Yeah, no, that's really reassuring as well for a parent as well, that that they do have that safety net, that they're not going home and then sort of see you later bye scenario. It's there's that follow up plan, and for later, or if something was to go a little bit pear shaped, they've got that contact and that ability to reach out to somebody and ask all of the questions, which I think is excellent.
For sure, definitely.
Wonderful. Well, that's pretty much it. Thank you so much for joining us on this particular episode, and no doubt you will be roped into more episodes down the track. But it's been really helpful and really enlightening to listen from your perspective on the watch and wait process and that particular method, and how helpful it can really be. And maybe one day, cross fingers, we might have a little bit of that in the adult field as well, but probably unlikely. Yes, so wonderful. Thank you so much for joining me.
You're very welcome. It's been great to be here and happy to help at any stage.
Wonderful. Thank you. I hope you all got a lot out of today's episode. Before we wrap up, here are 4 key takeaways from our conversation with Dr Melanie Jackson. Number 1, watch and wait is active care. This approach is about closely monitoring your child's symptoms and development, not ignoring them. Doctors are assessing risk over time and step in when needed. Number 2, many children with ITP will see their platelet counts return to a normal level within weeks or months without intervention, which is why avoiding unnecessary treatments is often the safest option. Number 3, treatment decisions are based on bleeding symptoms and not just how low a platelet count is. Signs like prolonged nosebleeds, blood in the urine or stool, or mouth blisters, or what we call wet purpura, are important to monitor. Number 4, you are part of the care team. Parents play a key role in monitoring symptoms, managing safety, and communicating changes. Knowing what to look for and when to seek help is one of the most important parts of this approach. A big thank you to Dr Melanie Jackson for joining us in this episode and for sharing her expertise in such a thoughtful, calm and reassuring way for families to navigate ITP. And of course, thank you to all the parents and caregivers in our community who are walking this journey and continuing to show up with strength, care and advocating for their children. If you're looking for support, connection or information, visit itpanz.org.au. You'll find The Count, our quarterly magazine, patient stories, treatment information sheets, clinical guidelines and a wide range of resources designed to help you and your family feel informed and supported. Most importantly, you'll know that you're not alone. There's a whole community here just waiting for you. If this episode was helpful, please share it with others in the ITP community and leave us a review on your podcast platform. It helps more people find Beyond the Count. We've got more expert conversations, patient stories and more coming soon. So hit the follow or subscribe button to stay updated. Thanks for listening as we go beyond the count together.